Keith, welcome.
Celia, hello.
As a pathologist, you are an expert on testing tumors, right?
Yeah, I have quite a lot of experience now of dealing with molecular testing of lung cancers in particular.
And what has changed in the last years in the testing of lung cancer?
Well, the diagnosis of lung cancer has become much more complex and detailed in the last 5 to 7 years. Formerly, the diagnosis was largely a histopathological diagnosis.
And that means?
Really how the tumour looks down the microscope,
yeah.
and then we classify it according to what we see.
Yeah.
And this information was of some value, but of probably, if I were to be honest, limited value in terms of determining how the patient should be treated. The biggest change that has happened in recent years is our ability to identify certain molecular changes in lung cancers which indicate the likelihood of response to particular therapies.
Right.
And those therapies are of, give considerable benefit to patients who have those molecular abnormalities.
And why should lung cancer patients have their tumor tested properly?
Well, for the reason that if the lung cancer patient has one of these molecular abnormalities that we can target with a specific drug, then we know from many studies now that the clinical outcome for that particular patient is much better if they receive the targeted therapy as opposed to if they receive what one might regard as traditional chemotherapy.
Right.
So the benefit is there for the patient, but they have to be tested in order to identify the abnormality, because you have to demonstrate the abnormality in order for the drug to be prescribed to the patient.
Right. And what should a lung cancer patient make sure they all get tested for? I mean, what tests should be done?
Well, to some extent it depends where the lung cancer patient lives and the health system that the patient is involved with. But for the vast majority of patients, there are rather frustratingly still only two what we might call routine molecular abnormalities that we should test for. The first is a little bit more common, and that is EGFR mutation. And the second is a rearrangement or a translocation involving the ALK gene. When that's present, that dictates that the patient would benefit from another type of drug.
You're saying frustratingly only these two,
yeah.
But what do you think the optimal testing would be for a lung cancer patient?
I still think that it is largely the testing surrounds those two markers.
Yeah.
The frustration that I describe centres upon the fact that we know that there are several other molecular abnormalities for which there appear to be therapies that we can give.
Yeah.
But many of these markers are so new or relatively newly discovered or understood, or the drugs have only just become available.
Yeah.
We don't yet have the trials, the evidence demonstrating efficacy to the satisfaction of the regulatory authorities so that we can have all these drugs approved.
Yeah, and if as a patient you were really avid in getting your tumor properly tested, how would you go about that?
Well, I think the key thing is to ask your physician about the possibility of testing. Do I have the type of lung cancer that has a chance of having one of these abnormalities? And if so, make sure that the possibility of testing is pursued vigorously.
Yeah.
It does, of course, require that a sufficient amount of tumour material is available from the diagnostic process, so that the testing can be completed.
And that means that enough tissue would have to be gotten out of a bronchoscopy or an operation, or
absolutely.
Yeah.
And whilst one can understand patients' reluctance and often true discomfort around having the samples taken, the necessity of the samples is really been increased so much by the possibility of carrying out these molecular tests. So the tissue is very important to allow us, A, to make the appropriate diagnosis, and then to allow us to go on and do the molecular tests. But we need the material to work with. Sometimes we do recommend to patients, especially if we believe from what we understand of the patient's situation and their disease, that there is a higher probability of one of these what we call targetable molecular abnormalities. If we think there is a higher probability and we don't have enough material to do the test, we would often recommend to the patient, you know, it may be worthwhile in your particular situation that we have another go.
What could be the benefit for the patient of having your tissue put in a database?
Well, one of the specific benefits that potentially might be realized for individual patients who enroll in studies where they allow their tumour to be more extensively analysed at a molecular level, rather than just two routine tests that we currently perform. It's possible, of course, to look for dozens or hundreds of different molecular abnormalities, which at some point in the future, either the near future or the far future, may allow the selection of new or emerging drugs to be given. And this may allow these patients down the line to benefit from some new therapy that comes along.
Thank you very much.
Pleasure.